So, consent. I think the ESG has just released a consent document, but this is the BSG one. I think they are relatively similar. You need to involve it. So we've talked the whole day. We've talked about patients being involved in the process. It's very important. If the patient got cancer, obviously they need to be involved in the process. If the patient's old and they've got a duodenal adenoma, they need to be involved in the process. Those are extreme cases where there's big risk involved or something, but everything really should involve the patient. And if it doesn't involve the patient, then it needs to be, if necessary, with their family or their caregivers. This is very important. The person completing the consent form, now this is very different in different countries. We all work in different environments. We'll just ask around the room in a minute. We've got Hungary, we've got Italy, we've got Belgium, we've got the UK, we've got Australia. So we can ask multiple countries what people are doing in kind of a sentence or two, have a think about it, about consent. And so this is a very English description, I think. And so this really covers the UK. The person completing the consent form. So in the UK, there is written consent, piece of paper done by the doctor with the patient personally before the patient goes into the endoscopy room. And that consent form is signed, and it contains pre-printed for diagnostic, but also there are therapeutic ones, what the risks and benefits are. And that person doing it cannot just be one of your assistants or one of your trainees, but it has to be you. What's Hungary?
Well, I think that there's a large heterogeneity how we do it.
Oh, okay.
I was lucky enough that in one of my workplaces, I was responsible for developing these informed consents, like 2 years ago, I think, 1.5. And I took many samples from the United States, from the United Kingdom, from Australia, and I made a four-page long document printed with font size 10, so it was really extensive. Because and then I looked at the guidelines of the BSG. At that time, the ESG was not there, and every point was included, so it couldn't be less than 4 pages with this font size, and that was for colon. The gastroscopy was 3 pages, so altogether it was it included all the risks.
But this document was a summary of the evidence, or this document was the thing you discussed with the patient?
The things that I discussed with the patients, the procedures that can be or could be done during the procedure, included that if there is a high-risk lesion found, then that will be a second discussion and not done at the first endoscopy.
Wow.
Yeah. So and I have briefly told the patients at our first encounter at an outpatient visit.
Yes.
I gave this document to them with oral instructions. They had a week or two when they came back to the endoscopy time, and then it was already signed, and then we just asked whether there was any questions before he came into the room or he came into the room.
Okay.
But yeah, I did this practice for 1.5 years. Previously, in another workplace, nurses gave informed consent to them. They read it and could ask a question,
but nothing written.
Written, but it was
so in
half
Hungary,
a page.
In Hungary, there is always something written with the patient. Most of the time.
Yes.
Okay.
Yes.
Italy?
I think also in Italy is very heterogeneous, but we have a paper that is signed by the doctors and can be also the assistant of who's going to perform the procedure and the patient.
Before they go into the room.
We definitely can't bring a patient into a room without consent having been done. I think in the hospital, sometimes it's not done that well because the consent's done by one of the interns or the very junior doctors on the ward who actually doesn't really understand the procedure. So I definitely feel like that the gastroenterologist or the sort of senior registrar doing the procedure ideally should be doing the consent and actually explaining specifically what you're going to do, what you're not going to do, and the risks. And I think it's really important, as well as talking about all the risks, that you also reassure the patients actually that these procedures are really, really safe, and that the chance of a major complication, particularly if it's a diagnostic test, but even in a therapeutic one, you know yourself what the risks are, that the risk is still very low for a bad outcome.
Yeah, but it's just one second, John. So it is, it's written though. It's written before they come in the room.
It's a written consent, but they don't physically have anything themselves. But yeah, it's a written
and
consent.
They've signed it. Okay. And just one second, John. Belgium, Lubke?
Well, in Belgium, for awake patients, you talk to them. We all have electronic files, and we can just say consent for the procedure and click yes without formal signature, and that will suffice. And it sort of implies as well that when the patient is there lying on their left side, have the mouth guard in, and
that's at the point when the consent is delivered.
Pardon me?
It's at that point that you are.
Well, it sort of is implied, and it's very different to sedated patients. We all have a written signature for sedated patients, and then at the same time.
But that is not a signature. That is not a signature for their endoscopy. That is a signature for their sedation.
No, for both.
John.
Yeah, just a couple of points to make. Firstly, there's something called coercion in English. So what that means is that you find yourself in a position where you have to go through something because you're under a little bit of pressure. So there is a couple of things in relation to consent. There needs to be a suitable timeline. So your awareness of when you're having a procedure done and the information related to that procedure must precede the procedure in sufficient time for you to be able to consider what you're being asked to sign. So there's a process here. It's not a one-off event. The second thing to say from our perspective is we have the ability for someone to consent the patient. So firstly, they get information leaflet and so on, and then they could get consented. And then when they come into the room, there's confirmation of the consent. And going back to some previous comments, in a utopian society, the person doing the test would do the consent. In reality, that is probably unworkable in many, many different situations, simply because of logistics, timing, and everything else. So you have someone else can take the consent, and then as the operator, what you do is that you then can confirm the consent with the patient, and you can fine-tune any of the details if you need to do that at that process. And we have the same problem in the UK, where actually our juniors, believe it or not, are being asked not to do the consents now. And some people will say that's a good thing, and others will say, well, how is the hospital supposed to function properly? And it's very interesting when you're on a ward round and you have some rare syndrome, they get their phone out, and within a millisecond, they can tell you everything you want to know about the rare syndrome. Yet they seem incapable of looking up the complications of different diseases and endoscopic complications. So it is entirely possible for someone who doesn't do the procedure to give a generic consent. And then if that consent is then confirmed by the individual, they can be much more tailored and specified if required. I appreciate there's a utopian society in this reality.
Yeah, I think that's very, very, very nice views from everyone. And I think that there's heterogeneity just in one country, but we've just heard the opinions of at least 5 countries, and it's different everywhere. So I think that that's something worth pointing out. I think we all agree that for high-risk procedures, we should be taking written consent. This is happening in my practice. I'm sitting with patients myself, and not with anybody else, talking to them about what I will do, and it makes me, of course, we're all doing consultation myself. Xander Peter is the ones here in Ghent doing it, but I want to see every single patient myself if I'm going to do something, to at least at least they have seen my face, and at least I've explained to them what the risks are, right? Of course, the benefits are hopefully the reason why they're sitting in the room. Okay, we've said that.
David, can I just come in there? There's a couple of things, as John would say. The first is that I don't think we consent patients for surveillance procedures very well. I don't think there's the key sort of phrase is shared decision making. And I think we should be, or somebody should develop some what they call shared decision aids. So there are shared decision aids for all sorts of things like cardiac catheterization and, prostate surgery and lots of different things. And I think we could do with one, particularly for surveillance and endoscopy. And the shared decision aid uses infographics and other ways of trying to help patients understand the balance of risk and benefits. So that's one point. Just one small observation I've had on our travels is that in Holland, there's no requirement to sign any forms. And the whole consent process in Scandinavia seems relatively loose compared to what we do in England. And I think the difference in the countries is the trust that the population has in the medical profession, which may or may not be justified. Which brings me to the final point, which is that when it comes to post-colonoscopy or post-endoscopic upper GI cancer, obviously there is a miss rate of pathology, almost inevitable, I'd say. But there is a question of what that miss rate is. And we could argue what that is, but really the miss rate of pathology should be within the consent process and often isn't. I'll finish there.
Very important observations. E-consent, interesting. I presume that's some sort of like electronic means of communicating with the patient up front, the procedure. Recommends, and they can sign it maybe. Is that what e-consent is? They can sign it online. Is that? I think those are very important comments, but if you want to summarize, and we'll just go around the room, is there anyone who would want, based upon the last one I did, is there anyone who thinks that propofol is not the gold standard for doing gastroscopy? No, I think that we can agree on that, and it's about resource and it's about managing how you get to that position. And finally, the mucolytic. We just wanted to talk about N-acetylcysteine. I'll just briefly touch on this then. So this is from the NHS Scotland Academy. We're really grateful to our collaboration, GIEQs collaboration with them. We've learned a lot from them and they, I think, from us. But if you're going to use something, this is what you can consider using pre the procedure. Infocol is a brand of simethicone. And then you have Parvalex, which is a N-acetylcysteine, and they are using this combination, which was published, I think, by James East in 2015, pre their gastroscopic procedures. And there is wide agreement that if you do this, and it's not very expensive, then you can make buckets of it up and then just siphon it off into little cups. I guess, I don't know, we're not doing it. Sadly, I've struggled to get the department to do it, but I hope that if someone's listening from the department, then they would start doing it here. I would like to implement it, that this really can make a big difference, because all the washing and everything, because time is not money in gastroscopy, time is patient tolerance in gastroscopy, especially if you're not using propofol. I think that you can waste valuable time by washing off the surface mucosa so you can get a better thing here.